Welcome back to part two of our two-part episode with Jenn Johnson, our ER nurse colleague from Canada and the author of Nursing Intuition. In part one, we explored the rural health background that brought Jenn into emergency medicine nursing and her insights into the grief and burnout and the unhealthy culture that exists for nurses, both in the recent past and in the current times. And with that, I want to pick up our conversation again. We were starting to get a little bit into the COVID-19 years. I feel like the COVID-19 years are this weird little secret that people keep trying to put in the past and move past, and that is not going to work.
Not in the slightest.
So, so we really need to go back a little bit. Jenn talked about how our interactions with the public can often be less than kind. They can be not appreciative. So, in general, when people are able to form a relationship with their healthcare team, usually they are more appreciative of what happened. They're able to express gratitude. They're even able to give grace. And in emergency medicine, we meet our patients for a very brief period of time. They don't get to choose us. They come in at the worst moments of their lives when they don't really have anything to give. They interact with us. We often carry out very silent interventions that may even save their lives. But it is not something that they're able to thank us for, or that they do thank us for. Our colleagues often don't thank us for it, the ones that receive those patients later. And then we also interact with patients that are at the worst moments of their life because they're having mental health crises, they're having legal interactions with the police when they're interacting with us. They are not there of their own free will. And we're put in the middle of that, again, not by either person's choice. So a lot of things happen without a lot of support. I don't know about Canada, Jenn, but in the United States, there is a movement to have mental health rooms, right? So they're basically empty rooms with nothing in it, so the patient can't harm themselves. But there is no movement to create 24-hour safety and security in the emergency department, because that is a much more expensive intervention, and it only serves the healthcare workers and the regulatory bodies that exert influence on our hospitals. Write regulations to support and to prevent and to uphold the health of patients, but they don't do it necessarily for healthcare workers. And we have a occupational safety organization here in the United States that has not delved into that space at all. Indeed, we feel very much abandoned by what they did not do for us during COVID as well. Tell us what it's like in Canada and what you've been experiencing.
Yeah. So mental health for us up here, we've got a Form 1. So if you are at risk of you're harming yourself or others, you can be put on a involuntary 72-hour hold, where within that 72 hours, you're supposed to be assessed by a psychiatrist. Again, getting people to the psychiatrist is half the problem, because these people are coming in to all the ERs, and only a select few have actually got access to the psychiatrists. So Niagara Falls was actually one who we had telepsych. And I could have sworn when they first brought in that television, I was like, oh, it's going to be busted in a minute flat for sure. You know, you're putting them in with, granted, a very comfy chair to sit in, but 2 desks, 2 computers, and then a television in front of them where they can talk to both the psych nurse as well as the psychiatrist and have the Form 1 either cleared or, say have the psychiatrist say, "No, no, we actually do really want them admitted. You're gonna have to transfer them to the satellite facility," kinda thing. And not only is transport exceedingly hard to do because, you risk, getting into the back of an ambulance with this potential patient who's sick enough to be actually admitted. So they're really at risk to themselves or others. And granted, they do have to be medically cleared before they go. But it's a risk. Sometimes you really don't know when people are going to snap or break or just, something just triggers them to the point where they have a reaction and you're stuck in the back of this box. So it's hard to be able to transfer people to where they've got to go. And then the lack of beds available is, again, a whole other can of worms where people are sitting in our ER for 48 hours, 72 hours, waiting to even get to the facility to speak to the psychiatrist. So we do have empty rooms. I think just about every place I've worked, there is one room where there's nothing in the room. So no suction, no oxygen on the wall, no call bell, nothing other than a stretcher that we can take out if need be. And we can put a mattress down on the floor, which is awful, but sometimes it's the thing that has to be done. And we've got a door that locks and a plexiglass window. And for the most part, most people are okay. But I mean, anybody who's even slightly claustrophobic, the room's pretty large, um, varying on where you're going, but it's still a locked door that all of a sudden you've lost all control. You've lost all autonomy. You can no longer do anything for yourself. There isn't a bathroom within the room. So you have to potentially pee in front of an open window and all these other kind of things. So there's a lot of shortcomings. We're trying as best we can with the whatever we've got. And if anybody knows how to MacGyver anything, it's an ER. But you know, it's hard, especially when you've got people coming back with repeated admissions and they get out of where they were admitted and then they just come right back into the community and they're within a day are having a relapse or are being triggered again or going back into the same situation that they left and having to be readmitted. And it feels like a revolving door, which is just it's disappointing that we can't do more for these people, um, other than, again, slap a Band-Aid on it and hope that things go well this visit, or something changes. But we're not providing near the amount of support that we should be. But again, it's hard with limited resources and limited staff and limited beds and all the things, as I'm sure it is everywhere. Um, yeah, so the telepsych was a great idea for when it was working. In 5 years, the TV was never once broke, which is shocking. Um, and it worked well because people at least were able to speak with a psych nurse, somebody who has got a much better idea and comprehension of the questions that you should and shouldn't be asking and how to interview someone a lot more in depth than the ER nurse who's like, "Hey, are you having any pain, any shortness of breath, any chest pain? No, no, no. Okay, I'll see you in 4 hours," kind of deal. And then, if the mental health nurse deems that, yes, they really do need to speak with psychiatry and ASAP, they'll get that arranged quite quickly. And so sometimes the psychiatrist will actually jump on right after the mental health nurse. So it helps to expedite things and gets people who maybe were just having a moment and maybe said something kind of off the cuff that we don't have the option of saying, "Oh, you were serious or not." We have to just take it as it is. And now, unfortunately, you're under that involuntary hold. Now you're having to wait for psychiatry. Now everything changes. Um, so it's hard that way. But, what do you do when there's limited access to everything, let alone like in the cities, let alone out rural? And, closest psychiatrist is easily 2 to 4 to 6 hours away.
Absolutely. So, you know what? The upside is telepsych works.
Yes.
Lots of things are working now. We have tele ICU where these smaller hospitals, right? Like
Yep.
the ones you've worked in and that I work in can get an intensivist on the line to help them manage a critical patient that you can't get transferred out. Just because you don't have the service doesn't mean you're not going to have to provide the service.
Mhm.
A lot of times you can't transfer your patient to the place that has the service. And so you're going to have to carry it out until that patient is there. It's kind of, I think of all this telestuff as like phone a friend for healthcare professionals,
Yeah.
right? So we're trying to build that on a global scale, like phone a friend. What do you need today? You need a cardiologist? All right, we'll get you a cardiologist. We'll phone a friend, because that does bring better care to the patients.
Mhm.
Look, the reason to do it is it's better for the patients and it's better for the clinician that has to be everything to everybody
Yeah.
because, like it or not, we're the safety net for everything in society. Not just here in emergency rooms, but in every place, right? In clinics, wherever there's a healthcare professional, those brief interactions become the place that intersects with everything. It intersects with what's happening in society. It intersects with what's happening in economics. It intersects with what's happening in politics. It intersects with everything.
Yeah.
So we have to be everything, a little bit of everything for everybody. So if we're going to have to do that, why not have everybody on a phone a friend?
They just brought forward telepeds, not telepeds psych, but telepeds. And it's a sister hospital that we're already kind of associated with. And the last time this happened, we ended up doing a telepsych as we were fluid resuscitating this child. And I ended up transferring this child over to the peds medical center. And thankfully, that was a doc that I had worked with previously. And I knew some of the staff when I came to drop off the kid because, granted, thankfully, the kid looked phenomenal by the time we dropped them off. And so, talking to the doc, I said, "Hey, had you not seen with your own eyes how bad they looked 45 minutes ago, would you be rolling your eyes at me right now?" He's like, "Absolutely, I'd be rolling my eyes at you." And I'm like, "But see, this is what happens when we're just trying to stabilize out and people, you know, especially the smaller hospital systems, we kind of get labeled as like the problem children because we're so in the middle of everything and we're pretty good at putting a decent band-aid on things where, they look all right by the time they get to the sister facility. And then they're like, well, why did you even bring them here? They look great. I'm like, yeah, now they look great. But before they did not look so good. So I'm happy that they can be discharged from your facility also.
Yeah. And that's kind of one of the things I think is the undercurrent to our culture that telehealth will help and it'll help us have more of a societal and a global perspective, right?
Yeah.
Because if we're doing telehealth and we're doing in-person work, we're getting some perspective on what it's like in those little places, right? And what the care is like. And that makes us better when we receive the patient,
Mhm.
of course, but it also makes us better stewards of healthcare in general. And it may actually help us be better advocates for healthcare system improvements.
Yeah.
So, more of that for sure.
And if nothing else, it's learning, right? Like now you get to run it by the specialist physician to be like, hey, in this scenario, this is what I would do. What would you do? And then you go back and forth and you talk it out and then you're learning. So not just, you know, the nurses are learning, but the physician's learning and everybody, it's that global collection of healthcare knowledge that is like coming closer and closer and closer together so that we can all kind of rise up together about like, no, we're all learning, we're all being better. Because again, the pediatric center, they do peds 100% of the time. That's all they do. So they're so used to seeing super critically ill children that when we send them somebody who's sick in our eyes, they go, well, this is nothing. so so help us then deal
Or
with
at least sick beyond your
yes,
capacity. Like it's
yes,
relative.
absolutely.
It may not be sick in their eyes because they have so much more capacity to handle variations of sick. But if you don't have capacity to handle mild sick, then that needs to go. you know.
Yeah, exactly. If nothing else, it's so much fun to like talk with the doc to be like, hey, what do you think? And bounce ideas and learn and learn and learn. Because while the doc's learning, I'm also learning. And I'm filing back for next time. Oh, so it's 20 per kilo bolus? Yeah, 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 yeah. Okay. And filing that back, in my head for next time so that the next time the doc goes, oh, what was the weight for pediatric dose? I'm like 20 per kilo. We're all learning and we're all growing and things get better. And it's so much fun to watch us grow also.
Yeah, that's pretty cool. So tell me about nursing intuition.
Oh,
How did you end up writing that book, and what are you hoping that people will get out of that book?
yeah. So nursing intuition was born out of COVID. I was working straight night shifts, so 4 nights on, 5 off. But my husband was also essential and in infection control, no less. So he was working Monday to Friday, 8 to 4, and daycare was closed. So I would stay up all day with the kids, who were 4 and 5 at the time when everything started, would work all night, stay up all day, work all night, stay up all day. Like, and it was just, I was out of my mind. I should not have been nursing. It was not a good place to be. But we had lawyers come forward to very graciously offer to do everybody's wills for free. So we kind of, yes, thank you for helping out and offering your services, but that feels like we're not expected to survive. Okay, so again, the anxiety, the fear, everything ramps right up. And, sitting there going, how do I explain to, or, how do you explain to a 4 and 5-year-old that mommy's not here anymore because mommy chose to go to work? We all had the option to not go in. We all had the option to swap careers. We all had the option to do all the things. We showed up, and I'll give us so many kudos for that. But it was hard. And so, having that mortality kind of really slap you across the face, going, okay, well, what do I want my kids to know about my career and why I chose to continue to go in? So my throat always gets me at this point. Trying to talk about all the really good instances of me helping, and then very quickly, all the bad stuff. It's one of those things where you can't help but have the emotion come up real fast all over again. And
It's PTSD, Jen.
oh, 100%. So hard. But
Yeah.
it was finally writing down all these stories and being able to work through a lot of stuff that I wasn't able to work through. So going through them, writing them down, the good, the bad, the ugly, all of it. And when I took a step back, it's like there's more to this. Like, I don't know what more there is, but I was listening to Llewellyn, who is a metaphysical publisher out of the US, and they were having online book fairs. And so one of the authors was talking about her book, Intuition at Work, and how you can use intuition in everyday kind of business scenarios. And I'm going, intuition at work. I'm like, I use my intuition every day. And it was just that light bulb moment of like, oh my God, that's it. So went back, went through all the stories, and sure enough, here's this thread of intuition. Did I get the ping? Did I listen to it? Did I advocate for my patient? Did it go well? Did it not? And having this follow through. And the more I started to open up and talk about it, the more other people would then open up. And my ER docs are phenomenal. And I'd say, when I come to you and I say, like, I just don't know, or I just have this gut feeling, what does that mean to you? And they said, well, you're really serious about it. Like, and that's why we stop and we come. And I'm like, thank you. And so I'm like, okay, so we all know that it's happening. We all believe that it's happening. But because it feels like a woo-woo kind of conversation, and because it just feels a little out there, it's relegated to a 3 a.m. conversation versus out and out talking about it in, not just to each other, but to teaching new students and all these other things. So, with it being 2020, and I'm like, I would love to put out this idea of intuition in nursing, but I am absolutely not going to even come anywhere close to it if there's not a ton of evidence on it, because, the misinformation, disinformation was just rampant about everything. I can't do it. and went on a deep dive and found not just so much intuition, or not just so much information on intuition, but specifically intuition in nursing. And I'm sitting there and I'm looking at all these peer-reviewed evidence papers, and I'm like, there's so much here. Why aren't we talking about this? Like, I can't understand that we're not talking about this. And so I'm like, well, if somebody's got to put their hand up and be the sacrificial lamb on the spit, it's going to be me. I'm gonna put myself out there because, if nothing else, if I can just help, one new nurse realize that this is happening, realize that there is ways to talk to people about it without coming across like you're absolutely nuts. Um, let's talk about it. And even the science says, so even if you're new and not sure if your patient's really sick or you're just kind of exercising this muscle, you go to your doc and you ask and you say, hey, I'm just not sure. Can you come and see? Just that doc having that extra touch point on that patient, you're still improving patient outcomes. So really, it is a win-win situation. Either your patient is sick, you've caught it, you're intervening and potentially avoiding a very traumatic scenario, or the patient's not sick, but you've you've trusted yourself, you've gone for it. You're wrong, that's okay, but your patient's still going to improve. So this is my whole message about, we need to talk about it because it's a very hush hush topic, and especially the ERs and the ICUs where we know that somebody's tanking and we don't understand why, and we're just not sure when it's going to happen, but something's going to happen. And so we talk to each other, and, especially the docs who are lovely enough to believe me when I'm talking about it and say, hey, Dave, I don't know what's going on with this patient over here. Can you please please just eyeball them? Like, they're super sick. Something's going to happen. I need you to take a look. And, oh, yeah, not a problem.
Mhm.
And comes up and sees my patient. And then if I'm wrong, he's lovely enough to explain as to why I'm wrong, or we go on a tangent about something else. But I'm learning no matter what. And you're never going to be right 100% of the time. But it's a skill that you can grow over the years. And it's absolutely just another way to advocate for your patients.
Yeah. I mean, we call it the spider sense on the doctor side in the ER, but it's the same thing, it's pattern recognition. It's a nonverbal recognition in your brain and your heart
Mhm.
that something is happening. And it's based on evidence. It's just not based on the sort of linear spelled out protocol
Yes.
that you're used to in medicine. It's just different
Yeah.
evidence,
It's
different pattern recognition for sure.
it's insight versus intuition. It's maybe something that you've overheard somebody talking about and you really weren't part of the conversation, but your brain kind of stored it. Um, and it's kind of where the art meets the science of nursing. And it's just
Mhm.
this lovely little apex where everything just kind of comes together. And when it comes together and it hits you, please listen. If for nothing
Yeah,
else, ask
yeah.
another nursing colleague, just, hey, I just don't know. Can you just come and see? Because I don't want to bother the doc. Like, I'm just not sure. And, talk to
I
your
think
charge.
that's the crux of the issue.
Mm.
We shouldn't have that where you're worried about bothering the doctor. I
Ah,
think that's the crux of the issue. There is attention is a huge issue for us
mhm.
as physicians in the ER, because when I work single coverage, I'm the doc and I have two or three nurses all taking care of the patients, reporting to me and doing the orders that I write and giving me reports on the patient. So attention and interruption and being able to finish a train of thought. I get it, right? That's a huge issue. Um, but I mean, underlying that feeling on the nursing end of I don't want to bother the doc is, um, I think, probably issues with staffing, right? The fact that we do staff that way where you're not working in an equal team, right? The other day we were busy and they called in more nurses and they were like, now we have four nurses. I'm
Whoa,
like,
how
that's
exciting.
super exciting, but I'm still one person.
So
I'm like,
we're very protective of you because
there is a rate limiting step.
I know. It's not that we don't want to bug you because like if something's really that serious, like I don't care what you're doing, I'm going to
Yeah.
grab you. But there is that learning curve as you're coming out as a new nurse where you're hypersensitive to all the different changes and it takes time to kind of really realize what sick, not sick, real sick looks like. But and they're timid. They're so timid to start usually. This new generation's
Oh, yeah.
this new generation's the honey badger generation. She's going for it. But but normally like you're just a little timid. You just don't want you don't and we understand. Like I understand when I'm standing there and I'm off to the side and I'm just waiting for you to finish your train of thought and I'm like, "Oh, I know that she can feel me here." Like, I know you can feel me, but I'm going to stay quiet until I hear you're fully finished dictating. And be like, "Hey."
Yeah. Yeah. That's super big. I mean, but there we need to have some recognition that we didn't create these systems.
Oh
Like
no.
these systems were created for efficiency, not for safety or effectiveness. Um, and that is underlying a lot of these issues culturally that we're left to deal with,
Mhm.
right? Um, we didn't even get to talk about the bullying.
I mean, there's always a second podcast.
There is always a second podcast. Indeed. And with that lovely segue, I think we might need to have a part two with
Hey.
Jen. There's definitely precedence for this. Part two with Jenn Johnson. What a lovely time just chatting with you today, finding out about um, the Canadian healthcare system. I mean, I'm hearing tons of similarities.
Yeah.
I definitely didn't hear anything that sounded like, boy, that's really different.
No, it's
Um,
not. It really isn't. It's just the same things. It's just different wait times. If you need a knee done, you're gonna wait a year to a year and a half to get your knee done. If you need, emergent surgery, hopefully it happens within a day or two. But other than that, we wait, and we're all very aware of having to wait. I actually had to explain to my daughter the other day. We were talking about how she wasn't feeling well. I'm like, "Oh, I'll just take you to the hospital." She goes, "I don't want to get you to have to pay for it." I'm like, "Baby, we don't pay." She's like, "What do you mean?" I'm like, "We don't pay, baby."
she's American.
No.
Your daughter's American.
Apparently watching too much YouTube or something. I don't know. But I'm just like, "No, baby, we pay taxes. This is why we pay more taxes for our healthcare system so that you don't have to worry about it." She goes, "Oh, but
She's a
what about the
capitalist.
medications?" I said, "Well, we do pay for medications, but most of us, thankfully daddy's got a benefit plan, so we can wean off of daddy's benefit plan." But, it's we're here to help. It's the same thing everywhere. Please do not stress about this at almost 9 years old.
Maybe she's listening to my podcast
She's
about how people go
she
bankrupt all the time and enter poverty from their healthcare bills.
I can't. So one of these days, I do need to figure out how American healthcare works because I have no idea. And, insurances and this, that, and the other. And when you have to run things by the people and they say no, I have no comprehension of that whatsoever. So I'll have to binge your podcast hard to try and pick it up.
That's crazy. Um, if you could ask for anything, I want to give you an opportunity to be aspirational here. Anything to address the issues that you see are pressing right now in nursing. Who would you ask, and what would you ask for?
Being the ER nurse, I would ask all of my family physicians to please have DNR conversations with your patients often and early. And I'm starting at 55 and just bringing it up and just lightly grazing on the topic during annual checkups, that kind of thing. Please, there's nothing worse than having somebody's wishes be fraught because nobody knows what their wishes are. So that I have to make grandma's chest soup because I'm doing CPR on her and she's full of cancer and there's no bones. There's nothing there. And that's traumatic for everybody. If I could get everybody to have a DNR status or at least having a conversation with their family physicians or somebody that they trust way before it's ever necessary, that would make me the happiest person in the world.
That would take a big cultural shift away from death and dying being
Yes.
seen as a failure
Yes, which is
in
all a whole
medicine.
other
that,
this is a whole other
that
thing.
would be a big, that would be a big cultural shift. But I love it. It's a great request. I think it goes to your the beginning, right? It started at the beginning, and the fact that patients die and it's not always predictable, or we're not even able to make it um, uh, dignified, or even make sense, right? Because sometimes we don't know anything before or after their death.
Yeah.
Um, and so I think that definitely brings us full circle back to that. How can our audience connect with you, Jenn Johnson?
You can find me on LinkedIn at Jennifer Johnson, BSCNRN. Please do not come for me. I had to use the BSCNRN because Jennifer Johnson's a ridiculously common name. You can find me on TikTok and Instagram at ernurse.jen, Jenn. My website is rx4growth, FOR growth.com. And yeah, I'm always here if you need a vent or just whatever you need. I'm here. I'm just hanging out.
And Jenn is also available for book sale. So please go to, is it
Yeah.
on Amazon?
So it's on Amazon, or if you want wholesale book sales for $10 American, you can contact me for anything over 100 books. We can definitely get you a discount on that one. And you can hopefully join the one U.S. health company or healthcare system who decide to order 6,000 books for their Nurses for Nursing Week.
Yeah. And Jenn is also available to come and talk with your nursing students or your nursing audience, especially around issues of intuition and burnout, and bringing back healthful well being to the most important nursing profession. Thanks, Jenn.
Thank you so much for having me, Dr. Kim.
My
It's
pleasure.
been a it's been a slice.
Okay, that's a new one. I have to learn that. It's been a slice.
Hey.
Woo! Thank you for listening to our episode, part 2 with Jenn Johnson. In our podcast, we frequently highlight and explore the vital role of collaboration between public and private enterprises, government support for sustainable health, equity, innovation. If you're a minister of health, a public health officer, a dedicated public official working to enhance healthcare access and equity, please, we want your voice also on the show. Please come share your valuable insights and perspectives with our audience. Contact us at drT at haew.org to secure your spot on the podcast. And listeners, we need you. We need your support. Please share today's episode with a friend. Leave us a review, please, 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 and share your thoughts. If you're interested in being a guest, please email us. And everyone, please visit https://haew.org to learn more about our programs, join us, partner, or donate to help get more of these conversations and connections to our audience and to help HAEW create healthcare equity impact for all.